Hello, my name is Jill Berry Bowen, CEO of Northwestern Medical Center and your host of the NMC Health Beat Show, dedicated to discussing important healthcare topics of interest to our community. Today, I'm talking with Jamie Pinkham, Compliance Supervisor, and Dr. John Minadeo, Medical Director of our Emergency Department. And we're going to be talking about a new rule that will govern how healthcare providers in Vermont will be prescribing opioid medication for acute pain. Wow. Welcome. It's good to have you here. So thank you for joining me today. So before we get started on this very serious topic, if you could tell our viewers a little bit about yourselves and what you do at Northwestern Medical Center.
Sure. So I'm the Compliance Supervisor, and I have been with the organization for 7 years, and my prime function is to oversee all things related to compliance, rules, regulations, policies, and this rule that we're going to be talking about today falls into that category very nicely. So I've been educating all of our providers across the organization on what this means to them as of July 1st.
Thank you, Jamie. Good morning.
Good morning. Thanks for having me.
Yeah, it's great to have you here.
I'm working in the emergency department. I'm one of the physicians there, and I've been there for about 18 years. And in that time, I've also overseen the EMS, and then more recently, I've been the director of the emergency department and urgent care as well.
Fantastic. So you're the experts this morning. So let's talk about opioid medication. So what is opioid medication before we start talking about rules regarding it?
It's a class of medications used to treat both acute and chronic pain, and it's a word that describes medications that are derived from the natural substance opium, and some are natural, like heroin and morphine, and then there are other synthetic types of medications that fall under that name, such as Percocet, Vicodin, fentanyl, you may have heard of, and OxyContin, which we'll probably talk some more about.
Great. Great. So these are things that you might order to treat pain with, these types of medications.
Exactly. And they're usually restricted for severe pain. So severe acute pain like broken bones or post-surgical treatment for pain. But then, as we'll talk about later, it's been used more for chronic pain as well, starting back in the 1990s, which kind of precipitated some of the problems that we're seeing today.
Right. And speaking about the problem, let's define the problem a little bit. And what is really the issue that Vermont and the nation is facing regarding opioid medication use?
Well, one of the good things about the medication and why it's been developed and used is because it's an effective pain control measure. However, one of the side effects is that it's also addictive. And so that's where the problem lies and why we're talking about it today. It's long been known. It's been treated, even from the Civil War and back in the early 1900s, it was treated. It was used to treat pain medicine, but it was recognized that it should be used very selectively because of its addictive properties. And it spiked a little bit in the 1970s after the Vietnam War, where heroin was quite easily accessible there, and so our veterans came back, and there was a notable problem with that. And at that time, the government felt that this was a very serious problem because there were overdoses noted, unintentional overdoses, and that rate then was about 1 in every 100,000. And compare that to today, when the rate is actually 10 times that.
Wow.
And so it continued to be used, but fairly selectively. And then over the past 20 years, since the 1990s, the use really jumped. And that's largely attributable to, we talked about earlier, chronic pain. There was a focus on chronic pain in the early 1990s, and it was felt that we were inadequately treating people with pain. And there were a couple studies that came out that felt that actually using opioids to treat chronic pain was safer than was thought to be. And so then the government actually felt that because doctors were not adequately treating pain, to make pain assessment, quote, the fifth vital sign. So they made,
okay.
You may have been, if you've had an interaction with the medical system, you may have been asked, what is your pain level, and rate it on a scale of 1 to 10. So this is one of the factors that increased the rate of prescription use. So in the early 1990s to the early 2000s, the rate probably quadrupled of prescriptions that were given. So what happens is there are now more prescriptions available out in the community and not being used. So there was a study by UVM and by Dartmouth assessing how much prescription pain medicine people actually use after surgery. So they're given pain medicine. Some don't fill it at all. Some fill it and don't take it. But they found that the average was about 26 to 28%, depending on which study you read. Okay. So that means that after surgery, there are 70 to 75% of the medicines that are just sitting in people's cabinets. So that's just more medicine in the community that has led to diversion, that has led to addiction, and so then more recently we've been kind of noticing this problem and scaling back a little bit. Pharmacies have been reporting issues. And so with that scaling back, an unintended consequence was the increased rise in heroin use, because now that people are addicted on prescription pills, with those being less accessible, heroin being more accessible and sometimes cheaper, they've kind of been drawn to heroin, which is actually more addictive. And then so we're seeing more accidental overdoses, and you compound that problem with fentanyl, which is another synthetic opioid that is much more potent than the other opioids. They're cutting that into heroin. So people may be taking heroin thinking that it's heroin, but it's got fentanyl in it, and so they accidentally will overdose because it's a far more potent medicine.
Wow. You've outlined the problem very well. Thank you. We've been part of the problem, and now it's time to try to rein that in, which brings this new rule about. So maybe a little bit of background. What is the rule, and what does it mean for Vermont providers?
So as Dr. Minadeo outlined, there was an uptick in prescriptions, and so and a lot of leftover medication. So this rule was a partnership of the Vermont Department of Health, the Board of Medicine, the Pharmacy Association, and the state to really try to mitigate exposure. So it's not so much a rule around folks who are currently experiencing addiction, who've already gone down the path of using heroin and fentanyl and those things, but really about preventing that first-time exposure and preventing the amount that's left over when folks do get these prescriptions. So the rule, the original rule came out in 2016, and it governed strictly chronic pain use, so opioid prescriptions for chronic pain. As of July 1st, 2017, there's now a layer of that around acute pain prescribing, so that when folks come to the emergency department, when they see their surgeons after surgery and they're assessing their pain, this rule is going to dictate the steps that a prescriber or provider has to go through in order to make sure that that prescription is appropriate and make sure that the patient is a good candidate for acute pain medicine. And it also requires informed consent on the part of the patient, which is new. That will be brand new for both chronic and acute pain. And it also requires that the provider have an in-depth face-to-face education session with the patient before they write the prescription. There's also a Vermont prescription monitoring system, which providers can use today to assess whether or not a patient is a good candidate. It's not required in all scenarios. As of July 1st, that will be required for any new prescription for acute pain opioids. And then there's going to be prescribing limits that the providers have to follow, which is very different. Right now, there's no limits governing. There's best practices, certainly, which I think most providers, especially in our community, are following. But now there's strict prescribing limits that a provider will need to adhere to, or they'll have to really describe why they're making the choice not to. And there's also going to be some consultation requirements, especially for pediatric patients, which studies have shown are getting addicted sometimes at the first exposure. So our pediatricians have also been really engaged in wanting to make sure that that first-time exposure is limited as well. And there's also some additional rules governing a co-prescription for naloxone, or more popularly known as Narcan, that prescribers will also have to write in certain scenarios to help prevent accidental overdose.
So what will a patient coming like to the emergency department or going to an office practice, could they expect if they're coming in with acute pain in regards to as of July 1st? What's going to change for them?
So it depends on the setting, really. It will look a little different in each setting. If they're coming for surgery, they'll expect to go through this process in their pre-op, potentially during their pre-op visits. The physician might have these conversations with them about what their post-op is going to look like and whether opioids are good for them. They'll sign an informed consent during that process. In an emergency department, though, if they're used to coming in occasionally and they receive a prescription for acute pain opioids, they'll have to sign some additional paperwork and talk to their provider a little bit more than perhaps they do right now. And I don't know, Dr. Minadeo, if you have additional thoughts on that.
Yeah, well, I think what they can expect, and they should expect, to have a discussion about non-opioid therapy for their condition as much as possible. To start with medications such as Tylenol, ibuprofen, other non-narcotics, and other modalities that would help alleviate pain, and to only use prescribed narcotics for a backup plan. And then they would have that discussion that's now kind of a more mandated discussion about the risks and benefits and the addictive qualities, about potential diversion of medications. And then, as Jamie said, they'll have to sign an informed consent as well, and they will be given an education form that has a lot of that same information on it.
And what will it mean for you and other providers? How will your workflow change? What does this mean for you?
Well, it means that it's going to be a little bit longer. So we'll have to have workflows that accommodate all the mandates of the rule, which means that it'll just take a little longer, but it won't be too much of a impediment, I don't think, on the patient's stay. First of all, we don't prescribe opioids very frequently, so the times that we do, it'll just be a little bit longer. I mean, to that point, this is a nationwide problem. It's not just a Vermont problem. And
correct.
And I looked earlier on the actual prescribe. They rank, the number of prescriptions written in each state, and we're actually 44th lowest in the nation. So we're already doing, I think, okay, and especially from the emergency department, we're pretty careful about who we give them to, and then also they should expect to not get a long prescription of medication. So if you have an acute pain condition, you might need opioids for the first day or two, but after that you should transition to non-opioid therapy. So they can expect conversations along those lines.
Great. Now, what if someone is being treated right now for opioid addiction, and they come in with additional pain or what have you? What's the implication for someone who's already in treatment?
So the rule actually allows for providers like Dr. Minadeo or surgeons to be able to treat that patient's pain based on their opioid levels. So they define a patient as opioid naive as someone who has taken who has not taken greater than 7 consecutive days of opioids in 30. So someone who is already in treatment, let's say with Suboxone or Methadone, wouldn't fit into that category. So the provider would be able to step outside those limits that I mentioned earlier and really treat that patient how they need to be treated based on their clinical judgment, and not so much worry about those pain limits. But again, it's going to come down to the provider's judgment. They're going to still have those conversations. All of those pieces are still required. It's not a guarantee that just because you're in treatment that you will automatically get a certain number of opioids, but the rule allows for providers to make those decisions based on the needs of the patient in front of them.
Okay. You mentioned something in your comment on opioid naive.
Yes.
What does that mean?
That's so a patient. The rule defines a patient who's opioid naive as someone who has taken less than 7 consecutive days of opioids in the past 30. So, for instance, if I were to present to Dr. Minadeo's site in the emergency room and I had just had my wisdom teeth out, I might have a prescription for 10 days of oxycodone, let's say, which is an opioid, and I might have only taken 3 days of it. So I'm going to inform my physician of that, and they're going to treat me as opioid naive. So they're going to use those limits to treat my pain appropriately, or maybe even have the conversation with me as to whether or not I need opioid for my type of pain. So that's the difference, and that's what that will mean for providers. So they will need to be aware and have that kind of conversation with their patients as well, because a patient who might use street drugs every day would be considered someone who's not opioid naive, and the provider can make a decision based on that as well.
Okay, great, thank you. Our time is going so very, very quickly. If you were to kind of sum up and what you want the community to know about what's going to change for July 1st, so they're well informed, what would you summarize our conversation that you want our viewers to know?
Well, I think it's that we, as the government and the medical community, recognize that there is a significant problem with diversion of prescription pain medicine, and we're going to try to do our best to limit the amount of pain medicines that we prescribe and focus them on those that really need it and for the briefest amount of time. And so along with that goes an acceptance with the community to accept that zero pain is probably not the goal. It's a manageable pain is where we want to get to, and to accept a willingness to try alternative therapy before opioids are the answer.
That's
a great point. Anything else you'd like to close us out with, Jamie?
I mean, I would just like the community to know how engaged all of the providers in this service area have been in wanting to do the right thing for their patients, to really take this rule and adapt it. It's been a really fun experience to educate everybody on this rule, and so I think our patients will be better off in the long run for it.
Great. Thank you so much. Thank you both for being on the show today. This is a really serious topic, and taking action as a state, I think, is really an imperative. So thank you for being here to inform our public.
Thanks for having us.
Yeah. And I'm Jill Berry Bowen, CEO of Northwestern Medical Center, your host of the Health Beat Show. Thank you for joining us and listening in on really the issue regarding addiction and how we locally and across the state are trying to tackle this to keep you safe, but also to help you with your pain, but managing it in a way that is hopefully possibly without opioids. So thank you for joining us today.